طيب بسم الله الرحمن الرحيم وبه نستعين والصلاة والسلام على أشرف المرسلين سيد الخلق أجمعين حبيبنا ونبينا محمد. طيب continue talking about mammographic peers and pitfalls. Today we are giving the part of the counterpart for the false negative. Today we are going to talk about the false positive. Suhair, can you describe the first image?
This is craniocaudal mammogram of the right breast showing high density, well-defined circumscribed mass at the posterior part of the breast related to the pectoralis muscle. Differential include variant of sternalis muscle and mass. So you have to see the mediolateral oblique because sternalis muscle not appear in mediolateral oblique view.
You said it is a circumscribed mass.
Yes.
Could you see the deep portion of the mass?
No.
So
partially circumscribed.
The visualized part of the mass appears to be circumscribed. As a radiologist, we have to describe what we have seen. Yeah?
Yes.
Okay. So it could be a mass, high density mass projecting over the pectoralis on the medial aspect of the breast. Differential diagnosis include sternalis muscles as a variant. So we have to do ultrasound. We don't expect these lesions, or we can look for the MLO view. If it is the mass, it might be visualized, but if it is not seen, still it could be a mass, because we said the lesion in extreme medial breast might be out of the field on the MLO view. Okay, and the sternalis muscle usually not visualized on MLO view. Okay, and what about this? This is more typical of sternalis muscle because of the flame shape appearance. And these are two examples of sternalis muscles as a variant. And when it is seen bilateral, it will be more easy, but in unilateral appearance, it will be sometimes a dilemma. But if we if we are aware about the variant, there is variant in this area, at least we will include it in the differential diagnosis and we'll search about it. This example of asymmetric bilateral, and usually on cross-sectional image it will be visualized. But if we don't know, we have no idea about a variant, even if we look for the cross-sectional, we don't know we are looking for what. But if we have an idea that there is a variant in this place, though it is not common, seen only in 5%, still we could appreciate it on the MLO, on the cross-sectional imaging, I mean, looking for any abnormality on the medial, extreme medial breast. If it is not there, we will look for any additional vessels on the extreme medial aspect of the pectoralis, as in the MRI and CC and CT arrowed image. And these here are examples of unilateral in the right, left, and on the right in the MRI. Okay, and this image and illustrations demonstrate the variable appearance, okay, of this type of variant muscles. And this is the muscle seen here. This is cutting in this axial MRI, and the muscles usually arising from the sternal notch of the manubrium sterni down to the end of the sternum. And here it appears as a flat, and this is the muscle projecting over the pectoralis muscles in the sagittal view from above down to the end of the sternum. It's okay. So we have many types of artifacts. We discussed some of or most of these before, that affecting the reading of mammography and result in a false positive or false negative result, either simulating a malignancy or obscuring underlying lesion that can represent malignancy. Yes, breast cancer is relatively common and remain the second leading cause of death in women. However, most of the biopsy results of breast lesions are benign. And all we agree that early detection of breast cancer, okay, and the state of art of cancer treatment are the most important strategies to prevent death from breast cancer. And the mammography still is a standard reference for early detection of breast cancer with a sensitivity ranging between 60 to 90%, and overall specificity up to about a range of 90%. And although significant improvement in mammographic techniques achieved over the past 50 years, still fundamental limitations remain. Last sessions, we talk about the detection of breast cancer, pitfalls, and we said that the detection relies on the ability to visualize cancer through background of overlying normal tissue that can result in a mask effect, reducing the mammographic sensitivity and obscuring underlying lesions, result in a false negative and therefore a cancer missing. Today, we are going to talk about the diagnosis and the ability to differentiate benign from malignant, and that might mimic breast cancer and result in a false positive result, reducing the mammographic specificity. If I ask you about this lesion, could you differentiate which one is benign and which one is malignant?
No, you can't differentiate between the benign and malignant.
If you ask me, I will tell you both are malignant, because both are high density lesions, are irregular, associated with a suspicious microcalcification. So both of which having typical malignant features, at least BIRAT 4C or even 5. However, the biopsy result on the right side turned out to be fibroadenoma, hyalinized fibroadenoma, while on the left it is invasive ductal carcinoma. If we will go back, then again we recommend biopsy, because definitely we cannot differentiate, we cannot guarantee these lesions unless having stability over years. Okay, we cannot say this is hyalinized fibroadenoma and just we leave it. We have to confirm by pathology diagnosis. Not only that, even the typical BIRAT2 hamartomatous lesions might in some point simulate and mimic breast cancer, okay, as in this case, presenting as indistinct or obscured high density lesions.
دكتورة رباب معليش الفايبرادينوما I couldn't appreciate the microcalcifications.
Yes, it is not very clear, but it is there. There are microcalcification. Okay. It is amorphous. It is amorphous. That is why not very
to detect.
Yeah, I could see it here in the close to me. I could see it, but on in the invasive lesions, invasive ductal is more appreciable than in fibroadenoma.
Yes. Okay. Thank you.
At the periphery of the lesions. Here it is
أيوة.
seen throughout, but here it's seen at the periphery of the lesion, which expected to be like that.
Okay.
Fibroadenoma. So, okay. So we agree any human work will never be complete, always associated with shortage. And last time we talked about the Alexander Bob ancient talks since many years. He said that to err is human, to forgive divine. ولكن قلنا the best talk is our prophet. قال رسول الله صلى الله عليه وسلم كل ابن آدم خطاء وخير الخطائين التوابون. ولكن لابد لنا أن نتذكر قول الله تعالى وقل اعملوا فسيرى الله عملكم ورسوله والمؤمنون وستردون إلى عالم الغيب والشهادة فينبئكم بما كنتم تعملون. وقول رسولنا الكريم صلى الله عليه وسلم إن الله يحب إذا عمل أحدكم عملا أن يتقنه. فنسأل الله الإخلاص في العمل. علينا أن نجتهد ونعمل وندقق لعل الله يقبل عملنا. طيب لنتخطى these pitfalls, okay, and obstacles, mammographic obstacles, okay. Our objective for these sessions is to review common factors leading to error in assessment and management of breast lesions, to demonstrate benign entities of female breast that can have malignant features on mammography, using case examples to discuss common and uncommon mammographic benign and malignant conditions that mimic breast cancers, and to review mammographic findings with pathology correlation to become more familiar with these breast cancers mimics and understanding their management. Okay, so first of all, let us understand what is false positive. Hint. So what is a false positive result?
A result that a mammogram that gives us that we think that this is a malignant lesion and then it proves to be a benign one.
Yes. So yes, mammogram demonstrates abnormality, though no cancer is actually present. This abnormality is due to other pathology conditions, either benign or malignant other than primary breast cancer. So for these abnormality, definitely require extra testing. If it is seen in screening mammography, definitely diagnostic mammography should be performed, then ultrasound and sometimes MRI or even biopsy, okay, to work it out and diagnose if breast cancer is there or not. And this when occur or when recall a female for a false positive result definitely will be insulted psychologically, and especially if the lesions, if the results of radiology pathology being discordance might go further for excisional, surgical excisional biopsy and result in substantial patient anxiety, time loss, and money loss, and physical discomfort. So we have to reduce the false positive as much as we can. There are factors that affecting the false positive results, like younger patients, those who have dense breast or had previous breast biopsies, family history, or taking estrogens. And about half of women getting annual mammogram over 10 years period will have a false positive finding at some point. And the false positive findings are highest for the first mammogram. However, those who have previous mammogram definitely will reduce the false positive by comparative study, and they found it to be reduced by up to 50%. Okay, if we would like to avoid something, definitely we need to understand about it. So what are the major causes of false positive? There are many benign and malignant disease of the breast that can mimic breast cancer. However, many of these can be sorted out based on imaging. Some could not be diagnosed until histopathological biopsy and histopathology diagnosis being performed. And we said these include include what? What are the major causes of false positive? We divide it into 6 groups.
Fat necrosis. And,
okay. Fat necrosis. Okay.
Scarring, like radial scar.
Hormonal replacement therapy.
Can you put it into groups to make it more easier? You see, it's almost all disease and conditions, abnormal conditions of the breast. We divide it into benign epithelial breast lesions, which are papillary and adenomatous lesions, miscellaneous breast lesions like fat necrosis, trauma, lactational changes, breast inflammation and infections, lesions like granulomatous mastitis, for example, lesion of the breast trauma, specific or non-specific, and non-epithelial malignancies like sarcoma, lymphoma, metastasis, amyloidosis, and fibrocystic conditions. So these almost all breast conditions and diseases can involve the breast. What are the most common benign causes of breast masses, female breast masses?
Fibroadenomas.
Okay. And
Fibrocystic disease.
which one is more common?
Fibroadenoma.
Fibrocystic. Fibrocystic is more common than fibroadenoma. See,
Okay.
we have almost more than half of the female, okay, at one time they have a fibrocystic disease. Almost 55 to 60 or more than that having a fibrocystic disease. Okay. Okay. Anyone, any volunteer would like to comment on this case?
This is mediolateral oblique and craniocaudal views of both breasts showing large, circumscribed, high density, macrolobulated mass at the left breast, occupying the almost the upper outer quadrant.
Outer? Is it outer or central?
It's central.
Upper central.
Central. No associated calcification or skin thickening. I couldn't
Can
appreciate.
you see the skin? Can you see the skin?
No, I couldn't appreciate the skin and nipple also.
Yes.
There are multiple axillary lymph node enlargement, not specific.
Non-specific lymph node. Okay.
Non-specific.
There is a similar smaller lesion in the contralateral.
In the right.
It is written here, the history, 17-year-old female with rapidly growing left breast lump. So what is your impression? And it is written here, the lesion is about 11 by 7 centimeter, and the right one is 3.7 by 2.6 centimeter. What is your impression about this?
I could put a phylloid tumor on top of differential.
Why you put phylloides on top of differential? Excellent. Why?
The age is not the phylloid not common in this age, but the history of rapidly growing breast lump going with the phylloid tumor.
Yes. What else?
Fibroadenoma also.
No, the other reasons for phylloides: rapidly growing, because of rapidly growing, and because of size.
It's a large, yes.
Yes,
large.
Because of large size and rapidly growing, we have to consider, okay, the phylloides high up on the top of the differential diagnosis. What is the differential diagnosis for this? Can give the same conditions. Also, it is rare, but can be overlapping in the differential diagnosis of phylloides tumor.
Fibroadenoma also one of the differential.
Which type of fibroadenoma that can be overlapped, especially with phylloides?
Giant fibroadenoma.
Yeah, giant fibroadenoma, any fibroadenoma 5 centimeter or more, it will call giant fibroadenoma. But there is a specific variant of fibroadenoma, okay, that can presenting as large or as rapidly growing lesions, and usually it will be might be large one, but at least rapidly growing. Which one? It is rare, but it is the phylloides in this group is rare. Okay, in this egg group is rare, but also this type of fibroadenoma is rare, but can be presenting with features simulating phylloides tumor, which is
juvenile fibroadenoma.
Excellent, well done. Juvenile fibroadenoma. It's okay. So the right lesions here is circumscribed, homogeneous, septated with some intralesion vascularity. Feature very typical of fibroadenoma, while the left one is heterogeneous, okay, with areas, look for these areas more hypoechoic, and even the internal structures, though it is circumscribed, but there is area of cystic component with adjacent focal skin thickening. You see, if you compare it with more homogeneous right one, this one is less typical of fibroadenoma, more in favor of phylloides tumor, these characters. Furthermore, when we go for MRI, again, following the conventional images, the right one is more typical of fibroadenomas, okay? Internal septation, more homogeneous, circumscribed, whatever, but the left one is inhomogeneous, though it is circumscribed, but it is inhomogeneous, and there is cystic area, non-enhancing seen here, and again, this is a cystic area, demonstrate high T1, low T2, okay? Might be proteinaceous or blood component with adjacent focal skin thickening. It is restricted diffusions, a heterogeneous enhancement, okay? So again, large lesions features more in favor of phylloides. However, the biopsy result, it was a fibroadenoma. At the beginning, the result before surgery, it was fibroepithelial, and sometimes even histology, not only radiological or clinical, even histological, sometimes there is some overlap and dilemma in differentiating fibroadenoma from phylloides, because both are a biphasic glandular and stromal lesions, okay, of the breast. Sometimes they have histological overlap. However, post surgical removal, the diagnosis was fibroadenoma. The right breast, after 1 year, the patient presenting by enlarging lesions with associated edema. Okay, post ultrasound guided biopsy revealed still fibroadenoma with associated proliferative changes. Okay. The second examples.
يعني في الرايت ما كان عملوا لها سيرجري دكتورة رباب.
No, because it is less than 5. It is less than 5, not rapidly growing. It has a typical benign features. So it is for follow-up.
Yeah.
Because the criteria for removal is either the lesion is rapidly enlarging or not very typical by imaging of being fibroadenoma or symptomatic, okay, or size-wise more than 5 centimeters.
Okay.
The criteria of for surgical intervention was not present for the right one. That is why they did not touch. But this is recent. This is done few last months. This biopsy. I don't know. After that, they remove the right one or they just follow it up. Okay. What about the lesions here in the right breast? This is a hyperdense, indistinct, and even here associated with some distortion, seem as if there is some speculations. But on ultrasound is also indistinct. Then it will be BIRAT, at least BIRAT 4. Post biopsy revealed a fibroadenoma. So sometimes fibroadenomas, though it is a typical benign lesions and just for follow-up, in certain situations, fibroadenoma can be atypical. When it is atypical, we have to recommend biopsy. Like epithelial fibroadenoma usually is hormone responsive, especially in pregnant lady, might get infarcted or get infected. And fibroadenoma also can be associated with proliferative changes like hyperplasia or sclerosing adenosis, resulting in a complex type. And in this case also it has to be excised when it is like when it becomes complex. And when it's getting hyalinized, it will be irregular, simulating breast cancer, and also early on, before in a baseline study, we cannot differentiate it. We have to do biopsy for confirmation, and especially if it's associated with microcalcifications before getting the typical popcorn type of calcification of hyalinized fibroadenoma. Okay. About these lesions, it is
the bilateral mammogram, CC, and MLO showing in the right breast, there is a focal area of asymmetry, retroalular, and an area of architectural distortion involving the posterior, the central posterior 1/3 of the breast.
Central posterior. Upper or lower?
Upper. It involves upper. The apical part of the fibroglandular tissue.
Okay, excellent.
طيب I can't see يعني I can't see
what is next? What is next?
Spot compression.
There is no spot, but this is zoom view. Could you appreciate anything more?
Yes, microclassifications.
Excellent.
Fine
Yes.
pleomorphic microclassification.
Okay.
The arrangement associated with the area of architectural distortion.
Yes.
It is arranged in
it is within the lesion, intra-lesions.
Yes.
So it will be?
It will be PIRAD 4C.
4C. It will be PIRAD 4C. Excellent. So this is ultrasound.
Type. The ultrasound shows the microcyst, I think, associated with the area of architectural distortion.
Where is the cyst? This, you mean here, this is ductectasia, okay?
Ductectasia, but I mean in the upper,
this is soft tissue. These are soft tissue.
Okay.
Different angle for the same area.
So just the area of architectural distortion.
Yeah.
And
here this is
with dilated ducts.
This is the area in the upper about 11 o'clock.
Yeah, associated also here, the microclassification is appreciated within it. So it's for biopsy.
Yeah, it is infiltrative hypoechoic process. Okay, parenchymal lesions for biopsy associated with ductectasia, and there are some small cysts scattered in both breasts. So the patient having lesions in the outer upper central and bilateral fibrocystic changes. This is the MRI.
In the MRI, this area showed heterogeneous enhancement. In the right breast. I just again for biopsy.
Yeah, it looks here. It looks like an speculated heterogeneously enhancing mass. It looks like a mass of heterogeneous enhancement, and the biopsy result it was sclerosing adenosis.
Sclerosing. Okay, focal tagging. كانت كيس بتاعت sclerosing adenosis.
قلنا what is the sclerosing adenosis؟
هو يعني entity من الفايبروسيستيك disease. بيكون فيه يعني enlarged acini ويكون فيه fibrosis في الستروما. ممكن يكون associated معه microcalcification والمشكلة the problem is that this patient عندهم higher risk to develop carcinoma يعني than the other populations.
اوكي. طيب الريسك عارفة كم في المية أو كم يعني by how
almost twice.
Excellent. طيب okay. Suhair, can you see a lesion in this image?
This is oblique view of left breast, showing area of high density mass.
Quickly, Suhair.
High density mass at the mid depth mid retroareolar.
Is it a mass or asymmetry?
Asymmetry.
Asymmetry is distortion. Okay.
Yes.
So what is your differential diagnosis?
My first differential is a breast cancer, and other differential include I put benign entity like sclerosing adenosis.
Okay, and
Fibroadenoma also.
Fibroadenoma? No. What are the
typical
kind of lesions that giving a focal area of architectural distortion?
This patient has post-menopausal with hormone replacement therapy.
Yes. Okay. That is why she has a dense breast. But what could it be? That the differential diagnosis for a focal area of distortion is, yes, we have to, since there is no biopsy or intervention, we have to think about breast carcinoma. Other differential include sclerosing adenosis and
sclerosing adenosis or papilloma also.
Yeah, yes, rare, yes, sclerosing papilloma can give yes, one of the differential diagnoses, but more than sclerosing, others, radial scar.
Yes, could be radial scar.
Or complex sclerosing lesions.
Adenosis.
Okay. Yes, you can see it now, and this is seen in ultrasound, and the case it was a radial scar. Differential diagnosis include Skirres type of cancer. It's okay. And this case,
Yes, okay. This is bilateral CC. The left breast showed an retroareolar skin thickening and a density from the retroareolar region going back, taking the shape of maybe of a duct.
Yeah, so we call it how many? How many?
This is single.
So we call it as
single dilated duct.
Yeah, or solitary duct sign or single dilated duct. So, and the patient having blood in nipple discharge. So, how we manage
ultrasound?
This
we go for ultrasound.
Okay, we go for ultrasound. This is ultrasound. Okay.
It shows yes a dilated duct or
short dilated duct, mildly dilated duct.
Yes. I cannot see the rest.
Symbol.
Yeah.
Is it
I cannot see.
Is it echo-free?
No, it's not echo-free.
Yeah. There is some internal echo. So complicated ducts. So what is next? We need another. I had done for her galactography. Okay. What does it show? What does it show?
Yes. There is a filling defect within it, at the posterior aspect of the duct.
Describe the filling defect.
It takes the shape of the duct itself. It's longitudinal, something. And
so non-expanding 2 centimeter smooth filling defect about few centimeter from the nipple within a major lactiferous duct. Okay, so this description is more typical of typical of
papilloma.
Typical of a papilloma. The locations and the appearance are typical of papilloma, and the patient underwent microductectomy. Pathology was papilloma. Okay. Medina. This step for you. أهلين.
Okay.
Welcome back.
عليكم السلام الله يخليك.
Mhm.
This is right breast CC anemia lobule shows there is a retroareolar or retroareolar density or mass
Mhm.
with inverted
Hyperdense mass. Hyperdense mass. Okay.
yes, hyperdense mass
Mhm.
with indistinct margin
Mhm.
and microlobulations,
Mhm.
inverted duct, inverted nipple, sorry.
Okay.
Um,
Only
mm,
inverted. Okay. Only, or there is some thickening. Associated thickening and
yes,
retraction.
there is, yes, thickening and retraction at the area of the areola only.
Okay.
But the rest
Mhm.
of the skin is unremarkable.
Focal, yes. Focal,
Yes,
nipple
focal.
areolar complex thickening and retraction.
And yes,
Okay.
and
What
retraction.
else? What else?
No abnormal calcification.
Okay. No obvious calcification. It's
Yes.
okay. What else?
Mm,
Any other abnormality or only this one? Mhm. We miss 1 hour, Medina. Would like to
yes,
compensate.
yes.
Quick. Any other
there is
abnormality?
في vascular calcification في lateral part of the breast.
Uh-huh. Okay, it can be due, might be diabetic or
Yes,
mhm.
atherosclerosis also.
Atherosclerotic changes.
No,
Okay.
no abnormal lymph
No
nodes.
other lesion. Can you exclude lymph node in this image?
Yeah, the
Can you
axilla
see
is
the
not
axilla?
shown. Yes,
Yeah,
no.
the axilla is not shown. The
Yes.
axilla is not shown.
Yes.
Okay. So what about that? What about the? Is it a single mass? When you have a lesion, you should look for other lesions. Is it a single lesions or multiple lesions? Is it important or not?
Yes,
So,
it is important, but
is there
only there is a density or area of asymmetry, but I think it is part of the parenchyma, breast parenchyma.
Is it normal or no other nodularity within this parenchyma?
Yes, yes, it is dense and nodular, but
yeah, these are other multiple equal density masses, small equal density masses extending into a segment. Okay, in the upper outer, extending down to the nipple. So I have a single lesions, retroareolar, and other multiple lesions. What is your differential diagnosis? No distortion or calcification or diffuse skin thickening. So what could it be?
Maybe multiple fibroadenomas.
Fibroadenomas.
Multiple
fibroadenomas. Fibroadenomas causing nipple retraction.
No, no.
So at least, if the pathology is fibroadenoma, you are not going to put in your differential diagnosis because it is not typical.
It's not typical.
It doesn't behave like a fibroadenoma.
Maybe يعني with
what
previous.
We said we have to judge by the most suspicious features. Is there any suspicious features in this image?
Nipple retraction and inversion or retraction focal skin thickening.
Yes. So at least this it will be BI-RAD.
Indistinct margin. I think it will be BI-RAD 4C.
Yeah. Yes. It will be at least BI-RAD 4B or C. At least.
Yes.
It will be BI-RAD 4. And so it is suspicious mass. So if you have a suspicious mass and you have other nodules, how you can explain these other small masses? So
maybe multiple cysts. I need to do ultrasound for her.
Yes, maybe. What is your differential diagnosis in this case?
Fibrocystic disease, maybe.
Fibrocystic disease. Okay.
Maybe.
But if you have suspicious mass and you have other nodule, you have to think about multifocal and multicentric disease.
Yes.
You have to think about this first. Since the mass, the index mass is suspicious, you have to think about to exclude multifocal.
Suspiciously. Okay.
What is your differential diagnosis? If it is not malignancy, if it is not at least not primary cancer, what could it be?
It could be METS or lymphoma.
Okay, what else?
METS or lymphoma.
Okay.
It could be inflammatory. Okay.
You see, look here. There are flecks of calcifications, and look for the nipple areolar skin and retraction, very obvious in the spot magnification, and the indistinct borders, okay, and microloculations. So it is suspicious lesions. This is the ultrasound. What about the ultrasound?
The ultrasound shows circumscribed. الصورة بتمشي. Shows circumscribed mass with different density and with different echogenicities. I mean, one of the there is basal soft tissue component of the cystic area in the left lower.
When you have a cystic area and you have soft tissue component, you call it as
complex cyst.
Yeah, so you have a large complex mass. You cannot see it all to tell if it is circumscribed or not, but at least there is a complex cystic mass with
portion
with solid component. Look like what this is projecting solid component. Even contain the microcalcification you have seen in the spot magnifications.
It looks malignant.
Flower-like appearance. This we call it as papillary projection.
Yes, papillary projection.
This is a papillary projection, and it is heterogeneous. Even the component of the cyst is not just echo-free.
Yeah.
See, it contains different
echogenicities.
Or fine
No color Doppler.
With posterior enhancement, not available here, color.
Okay.
It was vascular. It was vascular.
Okay. Oh.
So what is your impression here? Change or still?
No, I think it is. It upgrades the lesion. I will put it as PIRAD 5, and it is for biopsy.
Okay, it is for biopsy. But what do you expect to be?
It may be a papillary carcinoma.
Okay, which is rare. Okay, papillary carcinoma versus
versus.
This is the MRI. The MRI, following the conventional, demonstrate a heterogeneous, complex, cystic solid mass. Of different T2 fluid
intensities.
Surface component, and this is a segment of multiple smaller lesions in the upper central, well appreciated. And here the soft component is intensely enhancing and enhancement of the cyst, as well as enhancement of the nipple areolar
skin complex.
And the smaller lesion demonstrates solid enhancement and arranging into a segment.
Yes, a channel. Yes. Yeah.
So your differential, it will be under giving
type 2 curve. So what is your differential diagnosis?
It will be it is breast carcinoma, DCIS, or invasive ductal carcinoma, or or papillary carcinoma.
Excellent, excellent. Oh, yeah. Okay. This is 3 years back. The patient then brought at that moment when we diagnosed, that image was not available. We reported as virus 5, highly suggestive of malignancy by features, by characters.
Yeah.
But it was just a papilloma or multiple papillomas. You see, benign papillomas behave having or mimicking breast cancer. By time after, this is the papilloma, intracystic papilloma. After 3 years,
increases in size,
increase and infiltrating the adjacent nipples like malignancy. Okay.
Yes.
So papilloma can present by bloody or clear nipple discharge. Okay, and difficult by imaging. Usually by imaging is very difficult to differentiate it from cancer, and you need to go for biopsy. We'll talk about it in another times. We have no time to talk about this, the pathology. Okay.
Yes. Okay. Okay.
Because we'll talk about pathology later. But at least we have the examples of epithelial lesions. We went through which epithelial lesions we went through which. So here, how many epithelial lesions we discussed?
Fibroadenomas.
Fibroadenoma, okay. Papillomas,
radial scar, sclerosing adenosis.
Excellent. What is the difference between these entities? Yes, we went through sclerosing adenosis, papillomas, radial scar, and fibroadenomas. These are all epithelial lesions. What is the difference between these lesions? Three of them are proliferative, while one is non-proliferative. Which one is non-proliferative?
Radial scar.
Who said the radial scar?
Medina.
Why you select radial scar? Is fibroadenoma a proliferative lesion? Is it a proliferative lesion? No. The exception is fibroadenoma. The exception is fibroadenoma. All the three are proliferative lesions, while fibroadenoma is not. However, fibroadenoma might be associated with one of these, okay, proliferative. It might associate with hyperplasia, might associate with sclerosing adenosis or papillomatosis and getting a proliferative lesions. However, simple fibroadenoma is non-proliferative one, okay? What is the difference between the proliferative? What is the clinical significance of proliferative and non-proliferative? Why it is concerning us? Why we are looking for proliferative and we are saying this lesion is proliferative and the other is not? What is the significance for that?
The proliferative have great risk for
elevating the risk of breast cancer. Yes, yeah, as compared to the general populations. Women with non-proliferative have no significant elevations risk in developing breast cancer, while those having proliferative, they increase or they have a greater risk for breast cancer. Okay, we finished the epithelial. Just let us go for the second entity, which is stromal lesions. The stromal lesions we have either non-breast specific and breast specific. Do you know which type, which entities are in each type of these? Anyone? هناء هنا الهجوري معانا؟ هنا الأجوري or هنا different هنا؟ Okay, so the specific types, that means arising in the mesenchyme of duct lobular system. This include also fibroadenoma, because we said fibroadenoma is biphasic. What does it mean? That means it has two components. It has epithelial component as well as mesenchymal or stromal component. So it still can be included in the breast-specific mesenchymal or stromal lesions. The others include sclerosing lobular hyperplasia or fibroadenomatoid, similar to fibroadenoma, also having the two components, pseudoangiomatous stromal hyperplasia and phylloides tumor. Okay, all of these having stromal with variable amount of glandular or epithelial component. The other purely stromal, because are non-breast specific stromal, as the fibrous tissue, vascular structures, lymphoid, nerve, and skin. The fibrous giving the focal fibrosis, fibromatosis, and the hepatic mastopathy. Okay, and all these fibrous lesions are commonly seen in practice. Okay, and as we mentioned, usually stromal with various amount of glandular or epithelial component, and with exceptions of phylloides tumor and fibromatosis, they doesn't need to be surgically excised when diagnosed by histopathology. And to correctly differentiate between these types of the lesions, those we need to surgically excise from those benign, no need to excise it, and from breast cancer, definitely we have to be familiar with these entities and with radiology pathology correlation findings, okay, to understand the concordance and discordance lesions, and to differentiate which lesion necessitate to be worked further. Okay.
Question, Dr. Rabab. Yani fibroadenoma itself per se, it didn't need or it doesn't need surgery if it is benign looking and well-defined, circumscribed, etc. And
you did not attend the discussion of fibroadenoma. We discussed this issue.
Okay.
You left maybe of the net of your net. You have problem in the net.
Yeah.
We discussed. We said in the case of fibroadenoma, we said it was rapidly progressive. That is why if it was the large lesion and rapidly progressive. If it is large or rapidly progressive, if it is large more than 5 or rapidly progressive or causing symptoms like pain or distorting the breast. Okay. There are certain situations in which we need to surgically remove. Otherwise, just it is for surveillance, just to be followed. To be followed by imaging or clinical and imaging.
Thank you.
Certain situation, we have to remove it.
Okay.
Or if it is complex, if they have done biopsy and found to be not a simple fibroadenoma. If not simple fibroadenoma, then we have to remove it also. It have to be excised. If it is associated with hyperplasia or associated with sclerosing adenosis or whatever proliferative changes, okay, also then we call it complex fibroadenoma, and then it has to be removed. It will be proliferative lesion in this case.
Okay. Thank you.
Okay. So these lesions, this is our patient, 46-year-old female with history of mastalgia, left breast palpable mass. The first image, okay, demonstrate indistinct mass in the left retroareolar regions, okay, slightly medially. The follow-up after 8 months maybe demonstrate enlargement of that lesions. Ultrasound, you see, ultrasound also following the mammography demonstrate some increase in the original mass, okay, about 11, 12 o'clock position of the left breast. And furthermore, the borders become more indistinct, okay, than the previously, which necessitate to do a biopsy. We reported as probably fibrocystic changes or fibroadenomatoid lesions. I'll tell you why I reported like that. I noticed that, you see, it is similar or for fibroadenoma. However, when the borders, especially if the patient having fibrocystic changes in her breast, as in this patient, and I found this type of the lesions, okay, and the margins are fuzzy, more fuzzy than the fibroadenoma. Usually with fibroadenoma, the margin are more sharp and having a pseudocapsule. The lesion lacking a pseudocapsule and having fuzzy borders, I found to be, this is a part of fibrocystic changes, proliferative lesion, as in this case. You see, and it was pathologically proven, taken biopsy, and found to be a fibroadenomatoid mastopathy. Okay? So it is a proliferative, a benign proliferative lesions. Simulate fibroadenoma. Okay. This fibroadenoma we discussing in the epithelium and fibroadenomatoid two. The remaining two for breast-specific stromal lesions are pseudoangiomatous stromal hyperplasia and phylloides tumor. Phylloides, most of which we describe it also with lesions in fibroadenoma, and we said it is biphasic, you see, having epithelial as well as a stromal component, and the outcome is unpredictable by imaging to be malignant, or we cannot differentiate benign from malignance because there are three grades of phylloides tumor, either typically benign, this is pathological grading, benign, borderline, or malignant. You see, we cannot typically differentiate the three by the imaging. While that is why for phylloides tumor, usually the treatment is excision with what? Wide local excision. We have to take good margins because it has a high level of recurrence. Okay, this is regarding the phylloides tumor. Regarding pseudoangiomatous stromal hyperplasia, this is a benign, also simulating fibroadenoma. Okay, and usually just an incidental findings, but sometimes we might the patient might present by a palpable abnormality, same as the fibroadenoma, and sometimes by imaging you cannot differentiate it from a fibroadenomas. And usually seen in the premenopausal woman, same age group, and but sometimes might be diffuse type. In the diffuse type, the breast can be, the patient can be presented by huge enlargement of the breast, okay, and it will be sometimes might be ended by mastectomy, unilateral or bilateral. This is an example of dense lesions, so the angiomatous stromal hyperplasia, you see, and this is another example here with microcalcification and cystic changes simulating complex fibroadenoma, also stromal hyperplasia. And what about these lesions? This is bilateral mammogram, demonstrate what? The left breast is enlarged and diffusely with global asymmetry, okay, and micro calcifications. So what is your differential diagnosis for this diffuse and some edema is there? What is your differential diagnosis for global asymmetry with microcalcification and edema?
Inflammatory carcinoma.
Inflammatory carcinoma, excellent. What else?
Inflammation, and it could be mastitis.
Mastitis, okay. What else?
Patient مثلا subjected to radiotherapy.
No history of treatment. This is the first. She is a 31-year-old patient presenting with left breast swelling. This is a history. So could it be a tumor? Could it be a mass? Large mass enlarging the left breast. Like what?
Large mass.
When we said if you have seen very large mass, you have to think about we have to put in the differential diagnosis. What, Suhair? We have to put what, yeah, Suhair?
Phylloides.
Yeah, we have to think about phylloides. Okay, what about the ultrasound hint? Does it go into phylloides?
Yes. Here, large mass that you cannot see even the margins. Yeah.
Yes, huge involving most of the breast. That is why you could not see the margins. You see, and it is a heterogeneous, well-defined heterogeneous mass. Okay, but in this case it was non-vascular. And see it here in ultrasound and MRI, almost occupying the whole left breast and enlarging the breast. Okay, and not restricted in diffusions. And also there is some heterogeneity and cystic component. If you have seen it here, non-enhancing area due to cystic component. And it was low, very low on T2, intermediate on T1. Okay, this is the ferris phylloides. It was, the pathology was benign phylloides tumor. And after 3 years after excision, the patient presented by a mass at the same location. Okay, the mass is recurring, and look for the recurrent mass here. It is a well-defined. It is less than the first one, but it's still large mass. And look now, that very one vascular. Now is highly vascular. Highly vascular, and usually phylloid is characterized by high vascularity. But even the cellular fibroadenoma is also highly vascular. It's okay. And the other breasts also contain multiple similar lesions, relatively, you see, on elastography, appear to be hard, see, or stiff, relatively stiff. Okay. If you look here, this is soft, the blue at the level of soft, and green, then yellow, and no, the red is soft. The red one is soft, and then the green after which, and the yellow after the red. The softer is red, less soft is yellow, and hard is blue, and the green toward the in between, but toward the stiff part of the lesions. So
Okay.
stiff, those small stiff lesions, and it was also the result after biopsy. It was a phylloides tumor. However, in this time demonstrate character change on MRI. Not as very low as the first one on T2. Look now of intermediate heterogeneous signal intensity and demonstrate multiple non-enhancing septum, okay, within the lesion and is circumscribed, okay. And here also demonstrate this time restricted diffusion while the first one was not. So, and still it was a phylloides tumors, and the recurrence rate even in the benign and borderline is 20 and 25 respectively. So, okay. So we finish the specific breast specific stromal type, and let us go for non-breast specific stroma. And these we said include focal fibrosis, fibromatosis, and diabetic fibrous mastopathy or lymphocytic mastopathy. Okay. Here, this is example of focal fibrosis, and this can be presenting with wide spectrum, either circumscribed mass or can be even irregular border, high density mass with irregular border, microlobulated, indistinct, or even speculated, and usually heavily shadowing indistinct lesions on ultrasound. Findings are suspicious. And in this case, the lesion is seen, it looks same like the focal fibrosis, but have characteristic appearance being projecting posterior of the breast over the pectoralis. Okay. What does it signify? Being at these locations, okay, having the same appearance of stromal fibrosis, however, are infiltrating the pectoralis muscle. This is characterizing which type of lesions?
Malignant lesions.
We are talking about 3 types of lesion: focal fibrosis, fibromatosis, and diabetic mastopathy. Which one? You are going to select? This is usually seen with, this is an aggressive type of lesions characterizing fibromatosis, okay? And especially if the patient having implant prosthesis, it's being associated with, okay? This is another example of fibromatosis, also simulating breast cancer. You cannot differentiate it by imaging, okay? Look how it is aggressive, irregular, speculated, and on both ultrasound and mammography with shadowing on ultrasound. And in these examples, 29-year-old patients with long-standing type 1 diabetes mellitus. What does it signify, this history?
Diabetic mastopathy.
Yes, excellent. The history is going with the, we said diabetic mastopathy is stromal fibrosis, but is a reaction seen in the patients having long-standing type 1 diabetes. This is the history is going with diabetic mastopathy or lymphocytic mastopathy, and this is again another example of diabetic mastopathy, okay? Also showing hyperdense, irregular or speculated mass on mammo, and it's also suspicious on ultrasound. Okay. What is the findings in this image?
Okay. طيب. It shows in the inferior aspect of the breast, anterior part, a hyperdense mass, which is it could be asymmetry. It could be asymmetry, and yeah, more like yes.
Unless it is fulfill the criteria of the mass, you call it an asymmetry. Next, it will be
compression. Okay. Okay, it shows a focal area of asymmetry with extension into the subcutaneous fat up to the skin.
So we call it what?
Yeah. We'll call it what? Still a.
What is the name for it? The parenchyma is tenting, okay? It's tenting up and pulling the superficial layer of superficial fascia. So
tethering.
Yeah, causing tethering. This we call it is an element of fibrotic changes, but not like that one of the extensive fibrosis, stromal fibrosis, that one. But still, it is an element of fibrotic changes. Seen usually is fibrocystic. We call it a fibrous ridge. It's very common, very, very common cause of palpable abnormality. You see, during practice, you might be faced by this type, and usually ask the patient to put her finger and put your probe. You will see variable size of this type of palpable fibrous ridges. Okay, most of ultrasound breast reported as normal findings, and the patient having palpable abnormality. If retrospectively you come and do search, you will find it as a fibrous ridge.
وفي small cyst كانوا في small micro cyst. في الالتراساوند الفاتت في small cystic changes, micro cyst.
Yes, yeah. But doesn't explain the palpable. What explain the palpable abnormality is this one. And even with the size of this fibrous ridge, you can judge by the size of the palpable abnormality. If the ridge is small, you will find the palpable abnormality just small, like peanut or like that. If it is large, okay, and smooth, you will just feel it at the same. It will be corresponding to the clinical abnormality.
ويعني زي ده patient like this ما بناخذ لها biopsy.
Usually it is very typical. Yeah, if it is not typical, just you can follow the patient. If it is typical, just خلاص يعني it will explain her clinical problem.
Okay.
This 37-year-old lady with right breast lump. Suhair.
This is craniocaudal amidolateral oblique view of the right breast, showing an area of focal asymmetry.
Excellent.
Of high density of the upper outer quadrant.
Asymmetry.
At the upper outer quadrant. I cannot appreciate the calcification, but you have to do compression or zoom the image for more clarification.
There is no obvious calcification or distortion or edema or skin thickening or retrobaculations, just an asymmetry. Just an asymmetry. Next.
Associated axillary lymph node enlargement, non-specific.
Okay, this non-specific lymph node. Okay. What is next?
You have to do ultrasound for the patient.
Okay. Yeah, spot magnification revealed the same. The asymmetry was persist not. Okay, this is the ultrasound.
The ultrasound show complex solid and cystic component of the same lesion seen on
complex. This is how we can describe this here. Is it complex or
multiple small cysts?
we call it what? What do you call it?
Multiple small cysts, or
We call in the same area.
fibrocystic,
Yes.
or microcysts.
Yes.
Microcyst.
Yes. Clustered microcyst. We call it clustered microcyst in a case of fibrocystic.
Fibrocystic.
Okay. This is a case of fibrocystic, and we have to make sure these are not a complex, are pure cysts. Why? Because micropapillary DCIS can be presented as microcyst, but usually it will not be just simple. You might find some subtle distortion, subtle microcalcification, or complexity, soft tissue component. Look for these changes. So you have to follow it up to make sure it is not a micropapillary DCIS. Okay, and sometimes clustered microcysts can appear as microlobulated soft tissue mass on mammography, like this. Huh? Medina, it is your time.
Okay, this is CC and MLO of the right breast, showing central retroareolar hyperdense mass with a different density within it. The outlines is indistinct.
Yes, the most important is to describe the borders of the lesions, okay? This high density is a high density mass with indistinct borders.
Indistinct margin, yes.
So it will be BI-RAD.
It will be BI-RAD 4B.
Excellent, well done. It will be because there is no other suspicious features. No calcifications, no distortions, no edema, trabeculations, no skin thickenings. That is the only, so it will be BI-RAD 4B. I'll go for ultrasound to upgrade or downgrade it. Okay?
Yes.
Look for ultrasound.
Yes, it shows microlobulated cystic lesion with circumscribed margins. However, there is an angular point of the cyst bilaterally. The fluid inside is not clear. It's not anechoic.
So it contains debris fluid level and ductal extension of a duct contain the same, and the perilesion edema, and that was stable over 6 months because it was an inflammatory cyst. Because it was an inflammatory cyst in the case of fibrocystic process, fibrocystic conditions. Okay, so we said indistinct lesions sometimes can be just an inflammatory cyst, and the case it was having multiple cysts, multiple complicated cysts. This is one of the cysts, and ductectasia. Okay, but it was not just simple fibrocystic. Okay, complicated. Okay. So fibrocystic can be simple or proliferative. We'll talk about it later because of the time. Now we cannot dig into pathology. Okay, so we talk about many entities simulating breast cancer. We talk about epithelial lesions, stromal, some of the stromal lesions. We talk about the fibrous only, fibrous component of stromal lesions, and we talk about fibrocystic. Still remain 3. Yes, we divided into 6 groups. We have still remain 3 groups of breast disease and conditions.
inflammation infection. Wow.
Okay. Okay, this is 35-year-old female patients with left breast, underlying palpable mass, and left axillary lymph node. So here.
Mediolateral oblique view of both breasts showing well-defined, partial obscured, oval shape, equal density mass at the outer part of the upper part of the breast of the left breast, not associated with architectural distortion or microcalcification.
Are you sure? No distortion?
I think there is an area of
subtle distortion is there. Okay. Subtle distortion.
Yes, some speculation at the upper part of the
subtle, you can see subtle distortion or mild distortion is there. What else?
No calcification, no obvious calcification.
No obvious calcification. Okay.
But there is no skin thickening or lymph node enlargement also.
Oh, we mentioned that the patient having palpable left axillary lymph node. So why you said no axillary? You will tell the visualized part of the axilla does it show the palpable abnormality mentioned in the history? Because they told you there is, and you did not see the whole axilla. You will say the visualized part of the axilla doesn't show that palpable, clinically palpable abnormality. I would like to
do ultrasound.
Do ultrasound searching for this palpable abnormality to make sure about it. Right, okay. But about the skin thickening, can you compare the 2 parts?
Yes, there is a retroareolar skin thickening at the left breast.
Yes, you said no skin thickening. Yeah. You have to make sure first before you exclude things, you have to look at it carefully before exclusion. Okay. What is next? You said you want to do ultrasound. This is ultrasound. Now you could see the lymph node or not?
Yes, the lymph node show enlargement of focal enlargement of the cortex.
Focal or diffuse?
On the right one is a focal, and on the left one it B2B diffuse thickening of the cortex. I think it is 2 projection of the lymph node.
No, this is the left breast lesion. You have seen here. This is the breast lesions, and the image in the corner here. This is the left. This is the left axillary
lymph node.
Yeah.
It shows diffuse thickening of the cortex.
Yeah, diffuse cortical thickening. Okay. Okay. And the central vascularity, what does it indicate?
It indicates inflammatory.
Yes, inflammatory or reactive lymphadenopathy.
Or reactive
rather than being suspicious. Okay. Yes. Okay. And you have, this is what? This is the retroareolar.
The mass showing it.
This is the retroareolar, demonstrate.
Ductal extension.
Demonstrate ductectasia with internal component. Okay. And that is the lesions you have seen. This is the lesions.
The mammogram here.
Yeah.
It is a mixed echogenicity with angular margin and
where is the angular margin?
At the left part.
Indistinct.
Yes.
Indistinct lesions. Okay, no problem. Is indistinct. You can say there is some speculations. Okay, accept it. And this is the retroareolar, left retroareolar skin. Look how it's thickened. So, what is your differential diagnosis?
It could be inflammatory,
It
like
could be inflammatory, okay?
or infectious by any organism. Like
Yeah, it can be infections, can be inflammatory. Inflammatory like what?
granulomatous mastitis.
It can be granulomatous mastitis. Excellent. It can be what else?
Infectious, like infection by organism like staph.
Okay. Oh, if it is inflammatory, other than granulomatous,
TB,
could be
tuberculosis. Tuberculosis.
Tuberculosis is infections.
Oh,
I said
yes.
if it is inflammatory, other than granulomatous, inflammatory. Okay, the same patients, okay, same patients 6 months earlier. That is the lesion. This is the mass, okay, and look for the inflammations in the breast. Now she's improving.
It could be received a short course of antibiotic.
Okay, the patient might be received antibiotic or by itself it resolved or something, but still you did not mention what could it be, the differential in the differential diagnosis. Okay.
Yes, it could be.
Could be what?
Diabetic mastopathy.
No. Okay. What about this lesion? Okay. Continue.
This is spot magnification.
Okay, it came to you.
Showing high density, irregular, speculated mass. On ultrasound, it appeared to be hypoechoic with thick rim.
This is the first image. One is the first, one is a follow-up.
On ultrasound, the left one, I think the one on the left, it is a follow-up for that after receive treatment or follow-up by clinician. And on the right one, it is presented, the patient presented.
Okay, excellent. Type. Okay, what does it mean?
Resolution or response.
Yeah, resolving. The lesion is significantly resolving on follow-up. Okay.
Yes.
So how you characterize the lesions on ultrasound? Yeah, on mammo is highly suspicious, but
yes,
on ultrasound and the ultrasound follow-up signify that this lesions is
downgraded. I downgrade. On mammograph, I get.
Yeah. So
on mammograph, I give it by RAT 4B or 4C, sorry. 4C or 5. Or 5.
Yes. It is 5 almost. But on ultrasound, okay?
On ultrasound follow-up,
it was that suspicious, but the patient might disappear for any reason. She doesn't do the biopsy or whatever, and she came back after time, okay, after many months, with the lesion resolving. What does it mean?
I downgrade this lesion.
Yeah, significantly resolved within months, within the same years. So it is, what could it be? In your differential diagnosis presenting like this?
Fat necrosis, I put it as
fat excellent, fat necrosis. So the first case, this one, it was chronic inflammation with fat necrosis. You did not notice here, it is fat necrosis. This patient, our patient, fat necrosis, and the other patients also fat necrosis from the literature. The first one is ours, but this one from the literature, both are fat necrosis. Okay, and proven by ultrasound. They had done ultrasound and they found fat necrosis, and they follow the patient. The patient came on the follow-up with the lesion almost near completely resolved. Okay, this is our patient. You have seen it before. Hind.
So, 48 years old lady had history of breast conservation treatment for infiltrative ductal carcinoma. Came for 1 year follow-up. There is a density extending from involving all the retroalular area up to the posterior aspect of the breast. I need further imaging like ultrasound.
Okay, for the imaging, you need to, they said follow up after 1 year. You did not ask for the previous. You have to look for the previous. Huh?
So she had a surgery, from the previous.
Yes.
She did a surgery, okay, and then
So you did not ask which one the first, which one is the previous.
The one on the right, you say this the first one, and after she did a surgery and she undergoes treatment, and then she come like this with the one you show me first. She developed skin thickening,
but
and
I have shown to you the earlier one. This is after this is the first one. Yes, after surgery and radiotherapy. That is the one, and this is 1 year later. This is 1 year
later. So yes, the density decreased. So it most probably that was post-surgical features, for example, like what occurs after surgery, edema, and so.
And what is new?
There is yes, retraction.
The distortion is there, but the density, the asymmetry getting smaller, but you could appreciate some
microcalcification.
So what do you
in
expect?
A linear.
What do you expect this microcalcification?
Either due to for example, fat necrosis occurring after surgery, or it could be a new recurrence.
Okay, so but it's getting less. So you suspect more to be
fat necrosis.
And what about ultrasound? Does it help you?
Ultrasound. This is what there was the previous one, and on the left.
Yes,
the right.
Same orders.
Yes.
The one projecting over the previous, and the other one projecting for the recent is the recent one. So
also there is decrease in the size.
And the appearance is fitting with
seroma.
Fibrosis.
Fat necrosis. Yes, it is a fat necrosis. It's resolving fat necrosis, post-surgery fat necrosis. Okay.
Okay.
Seroma,
yes, seroma, but not a simple seroma. It is a fat necrosis filling the seroma cavity. Okay.
Okay.
Associated with fat necrosis. Okay. So fat necrosis is an inflammatory process considering the miscellaneous group of the breast conditions. Okay. So in addition, cancer mimics may also be caused by inflammatory process like foreign body reactions. Can you give me example for foreign body reactions? Like what?
Implantation. I think implantation.
Yes, implant rupture. Okay, a silicon granuloma, or what about sutures? You haven't seen suture calcifications? Suture calcifications, and sometimes even the needle, the sewing needles, okay, can introduce, or any foreign body can be introduced like other part of the breast, traumatic, you see, and giving some reactions. These reactions can be suspicious, simulating cancer. Okay, mastitis, anaphysis, trauma, including hematoma, fat necrosis, and lactational changes. And we said usually fat necrosis following trauma, either direct trauma or surgery. Okay, and these other entities, including in the inflammatory process. Okay, can you tell me about these lesions? Now, the order.
This is bilateral MLO views of both breasts. Shows circumscribed, extremely dense mass-like structure in the anterior central part of the right breast, resembling breast augmentation or
there is no breast augmentation.
Oh shit, my God.
What else you would like to ask? No augmentation.
The age of the patient and the complaint and previous past medical history. Is the patient
This is a past medical history. Huh? 2 years earlier. Excellent. You asked about the previous. That is a previous.
Okay. There is the mass, the dense mass seems larger and occupying almost most of the breast, of the right breast. It reduces in size.
Excellent. So we are dealing with
breast mass.
Does it help you? The previous does help you? The previous image?
Yes. The ultrasound also shows well-defined cystic lesion with echogenic material also. And
so if we call it as if it is a cyst with echogenic. So it means
yes, it means anaphysis.
It means how description wise?
It means complicated cyst.
Complicated or complex?
Complicated.
Why is it complicated? Are you sure this hyperechogenicity is fluid? Okay, No
No.
problem. So it is complex. It is complex until you make sure what is the nature of this hyperechogenic. It might obscure something in underlying, or itself it might be hyperechoic soft tissue. So you don't know, you have no Dopplers. It will be apparently complex lesions of two different hyperechogenic and cystic component, and the lesion was big. Okay.
Yes.
Now it's getting smaller. While getting smaller, it has tail-like. You see?
Yes.
Like
Posterior tail.
okay. Could you get any impression about this? Any differential?
It may be fat necrosis.
Okay.
I see a fat particle within the ultrasound occupying the upper part of the cystic or the cyst-like lesion.
This is the 5 years later from the original study. From this one. This is after 5 years.
It gets smaller in size and less denser. Even
Yes.
the density it gets less.
And is it now? Is it one or other lesions are seen in the vicinity?
Two nearby lesions
What
overlapping.
What about the new lesions seen in the vicinity? Same characters or different?
It seems same lesions with less density, also circumscribed.
Now are loosened. These are loosened lesions.
Yeah.
So we are dealing with
oil
is it
cysts.
a benign or malignant lesion?
It seems benign.
Okay, we are dealing with benign lesion, huh? We are dealing with the benign process. What could it be? History?
Hematoma.
Excellent, well done. You got it. Yes,
Yeah.
It is a hematoma because acutely following trauma. The history was a lesion acutely following trauma, and the hematoma persists, just regressing in size and complicated by adjacent fat necrosis. And the traumatized tissue adjacent develop fat necrosis. So
extremely dense mammography.
Yeah, some of the mimickers for breast cancer. Okay.
Okay.
Okay. Next.
Yes.
سهير or Hind? The order for سهير or Hind?
أعتقد أنا ما متأكدة.
Okay.
طيب ultrasound and bilateral mammogram CCVO. The left breast shows a global asymmetry.
Excellent.
No associated features. I can appreciate other features. Ultrasound shows thickening of the skin and edema, signs of edema.
What are the signs of edema? Excellent. What are these signs?
There is hyper-echoic, the subcutaneous fat becomes hyper-echoic.
Excellent. With lack of differentiation between the tissues, okay? And
Yes.
And what?
There are dilated ducts.
These ducts or subcutaneous lymphatics?
Yeah, yes, it is subcutaneous lymphatics. Subcutaneous, it's not within the breast glandular tissue, and in the setting of this edema.
Yeah, these are subcutaneous lymphatics. So look for the history. Before
a diabetes patient presenting with rapid onset of breast pain on the left with swelling and redness.
So the history, the clue in the
suggested
history.
inflammation, يعني inflammatory process or infectious process.
Infectious process, like
Mastitis.
which type of mastitis? Secretory mastitis?
لا. diabetic mastopathy. ما أعرف diabetic mastopathy. I don't know.
The patient is diabetic, that means expected to have
bacterial infections.
Bacterial, this is the bacterial mastitis. You see, this is acute bacterial mastitis. The clue in the history. So mastitis, we have berberal or non-berberal mastitis. And this one, this lady having, I forget to put the age of the patient. That was non-berberal bacterial mastitis. We have berberal mastitis. When on berberal mastitis, we have plasma cell as bacteria. And we have plasma cells and granulomatous mastitis. Okay?
Okay.
So here, it's yours.
This is craniocaudal and mediolateral oblique of view of left of right breast, showing high density speculated mass at the center, mid center of the breast, with associated microcalcification and adjacent retroareolar skin thickening with like density projecting from the mass to the retroareolar density. The axillary, yes, there is axillary lymph node enlargement seen at the mediolateral oblique. Ultrasound show deeply hypoechoic mass with angular margin, not parallel to the skin, with some speck of calcification inside the mass, and posterior caustic shadow, like see shadow right.
Yes, you are right. Posterior caustic shadowing, يعني moderate, posterior caustic shadowing and perilesion.
Yes, perilesion and edema.
Edema, excellent. So,
so I give it BI-RAT 5.
BI-RAT 5, agree, totally agree with you. For biopsy, what do you expect the result it will be? If I'll tell you inflammatory, I'll tell you it's inflammatory, you think about
granulomatous
mastitis. This is granulomatous mastitis simulating cancers. Okay.
Yes.
The result was granulomatous mastitis. Without histopathology, you cannot decide.
Yes.
You cannot judge. Abir, you are welcome. Where are you? We miss you. And this is another patient. Okay.
السلام عليكم ورحمة الله. دكتور رباب مساء الخير.
Where are you?
والله دي بصراحة أنا ذاتي حزينة إني I didn't join early. لكن كان الليلة شغالين وكان عندنا أكاديميك كده، كان عندنا lecture.
Okay.
فيا دوب وصلت البيت فتحت التليفون على طول.
Okay, you're welcome. Okay, this is another patient of granulomatous mastitis, diffuse type. Okay, simulating also breast cancer with global asymmetry in the left breast and axillary adenopathy. Okay. What is granulomatous mastitis here?
Inflammatory disease, breast inflammatory disease. It could be mimic breast cancer or inflammatory breast carcinoma.
Yes, yeah, especially the inflammatory breast carcinoma. Yes, because usually having diffuse breast edema.
Yes.
Clinically, radiologically also. Clinically and radiologically can simulate breast cancer, especially inflammatory breast carcinoma. Diagnosis by exclusion and histopathology.
Also
Characteristic findings.
histopathology.
Yeah, what are the types of granulomatous mastitis? When we said granulomatous mastitis, what are the types? We have secondary granulomatous mastitis, secondary to organism or secondary to autoimmune process, like what? What are the granulomatous infection?
Tuberculosis.
TB, excellent, Medina. Yes, it can be granulomatous to tuberculosis, to
Sarcoid, also sarcoidosis.
Yes, as autoimmune sarcoidosis or fungal infection or polyangiitis. Okay, these can be, or also granuloma like foreign body granuloma, like silicon granuloma is also granulomatous mastitis. You see, but we have also idiopathic type. All are rare, and the idiopathic is more rarer, extremely rare, or very rare disease, and we call it what the idiopathic type. It has a name. The idiopathic granulomatous. What is the alternative name for idiopathic granulomatous mastitis? You did not study well, Suhair.
الجرانيولوماتوس ما قريت كلها للآخر صراحة هي والليمفوما.
You have to go and read again. And also Hind and Medina, they did not study.
Yeah, admit.
Why? You have 1 week. Why you did not study?
أنا كنت بقيت شغالة بقيت حالتي تحنن.
Okay. What is the name? What is the name of idiopathic granulomatous mastitis? We call it granular lopular. Okay, Gunna is non-lactating chronic mastitis, primarily in women of childbearing, and very similar to those breast carcinoma clinically or radiologically, can be misdiagnosed, and the idiopathic diagnosis by exclusion of other causes and histologic pattern, okay, combined together, and we have to exclude what reaction to sarcoidosis, Wagner's, granulomatosis or polyangiitis, and especially tuberculosis or fungal infections. And you can read about it here. You can take all information or most of the information related to granulomatous mastitis. And also we have uncommon inflammatory and reactive diseases of the breast. You can see it in this table. Okay, and Hind, I think it is your time, or Medina? Which one?
Yes, I think. Bilateral breast mammography, CC, and MLO, showing bilateral calcifications, rod-like.
Excellent.
Just I'm magnifying the image. Yes, benign macrocalcification.
So this is what we call this entity?
Plasma cell mastitis could occur.
Yes, this is a plasma cell. This is a plasma cell mastitis. Okay, so we said one of the entity of the inflammatory mastitis is a plasma cell mastitis. Here in this case, it doesn't show a suspicious feature, but sometimes might be associated with periareolar skin thickening, especially if it is unilateral, or can be associated with other things like in this case. What's the suspicious feature in this case?
Skin retraction, skin thickening, and nipple retraction.
The thickening and retraction of nipple areolar complex. So is a common findings or common feature characterizing this entity of inflammation, benign inflammatory process. Look here, this is not secretory mastitis, but is due to what is the cause of nipple retraction in this case? It's very clear, very obvious from mammography. Confidently, you can say this is due to.
Actually, there is a high density taking a ductal distribution.
Yeah. Yes. Especially if the patient has previous images, you will confidently say this sequelae of ductectasia. Okay. And the commonest cause of nipple retraction is ductectasia, especially in elderly women. And here, bilateral, mild, and even you have residual fibrotic ducts. These are fibrotic ducts seen on ultrasound with subsequent mild subtle ductectasia and subtle skin thickening. What about these lesions? What about these retractions? Are you confident to say this is just sequelae of ductectasia? You might say yes or no. If you look at it and you have seen some thickening and retraction and you couldn't see any distortion, asymmetry, masses, or suspicious calcification, and you are not sure, you have seen an opacity far away here, tubular opacity, you don't know what is going on, just you have to check for the previous. If it is stable, seen in the previous, that means this is a sequelae of ductectasia and full stop. Plus, BIRAT 2. And what about this? Here, this is bilateral inverted nipples. It is seen in 10% of women. 90% of women having inverted erectile or protruded nipple. But we have 10% having either flat or inverted nipple as a variant. Okay, also, especially if it is unilateral, it will be mimic breast cancer. Okay, what about this one? Abir, it's yours today. This is your time. The floor is yours.
Okay. These are CT views and MLO. Of breast ACRB. Showing diffuse different sizes, dense lesions scattered over both breasts bilaterally.
What is a striking abnormality appear?
There is a retroareolar.
Yes, you have to start by an elephant. Yeah.
Okay.
If you have an elephant, you have to start by an elephant.
Okay. There is retroareolar left breast mass. Higher density than the breast parenchyma.
Okay, you a high density retroareolar mass with. Be fluent. You know now. You know how to characterize the mass by density and morphology.
Yes.
You mentioned the density, high density. What about the morphology? Is it regular or irregular mass?
It's regular rounded mass with a partially indistinct posterior border.
Indistinct only? Okay. And speculations, yeah? There is some speculation and distortion associated with?
Yes, associated with architectural distortion. And there is a mild skin thickening. So I will put it by RAD5.
Okay.
For tissue diagnosis.
Okay. And it was invasive ductal carcinoma. Okay. So?
Regarding the other appearing diffuse small dense lesions, is it an artifact?
No. Not artifact.
So it's on a background of ductictasia, this lesion. So this lesion be on a background of benign breast entity, ductictasia, I mean.
This lesion representing ductictasia?
No. I mean regarding the diffuse bilateral dense lesions in the breast. I mean this lesion on a background of ductictasia.
No. You mean you are thinking about cyst? You are thinking about fibrocystic, you mean?
Yes.
But why you think about fibrocystic? Can you characterize this lesion more? What about the distribution?
They are diffusely scattered bilaterally in both breasts.
Only both breasts?
And even the axilla, maybe they are just artifacts, hydrants, I mean.
I told you no artifact, no artifact. Are real on ultrasound, seen on ultrasound, huh?
So they could be just skin lesions like sebaceous glands?
No, not the skin. Are seen subcutaneous and within the parenchyma. Yes, it is a rare thing, but you have to think about it. You have to think about what?
Multiple neurofibromas, but are not typical.
No, not. I told
you.
I told you within the parenchyma, and subcutaneous. So you have to think about something, and not neurofibromatosis. It is skin. This is a dermal. Yeah, this is not a dermal lesion. This is a parenchymal and subcutaneous. Any suggestion?
Metastasis.
Metastasis. We have to think about metastasis. Okay? Because the patient has primary. I told you the left breast lesions is invasive ductal carcinoma. So this is a metastasis, though, is unusual, very unusual.
Okay.
This patient, they said 3 years back, had a normal mammogram. Now she has innumerable small lesions of variable size, scattered throughout. It is proven to be metastatic lesions, very unusual appearance. Okay, and the patient, they said, have no enlarged lymph node, even not only on mammography. Here we cannot exclude it, but even on ultrasound has no axillary lymph node. This is another patient with bilateral metastatic disease. Okay, it appears, usually this is the appearance for metastasis. Usually it's circumscribed, okay, round or oval, mostly will be circumscribed, but can be indistinct, okay, and associated with axillary lymph node, and scattered within the parenchyma and subcutaneous part of the breast. This is the usual appearance of, and this is example again of breast metastasis from clear cell sarcoma of the right arm. But here, the part of the lesion circumscribed and partially obscured, associated with extensive edema and seen as a complex lesion on ultrasound. And intense uptake of the seen with intense uptake of FDG in the PET scan. Okay, the PET scan demonstrates or shows hypermetabolic foci, high uptake of the FDG. Scintigraphy. Okay. So the difference between breast metastasis and primary cancer, the primary cancer definitely very common, while metastasis is very uncommon, only represent up to 2% of malignancy in the breast. And metastases usually tend to be found in the subcutaneous, while the primary is usually seen within the gland. Metastasis manifest as usually multiple but can be solitary, while the primary is usually solitary but can be multiple. And metastasis much more likely to be multiple and bilateral than the primary. Okay, primary have irregular border, microlobulated, indistinct, or speculated. Okay, while the metastasis usually having a regular shape, oval or rounded, and usually circumscribed, but can be just indistinct. But it tends not to have speculated borders, the metastasis, and even not seen to be associated with skin retraction or nipple retraction, unlike the primary lesion. If you have seen skin changes, retractions, or nipple retractions, think about primary, not about secondary. Even our multiple lesions might be a primary lesion. However, some of the malignant lesions might have the characters of metastasis, seen as circumscribed, regular, oval, or rounded lesions, as we described before, the mucinous, medullary, papillary, phylloides, and high-grade invasive, and especially the triple receptor negative breast cancer. They can present like the metastasis or even like fibroadenoma. Okay, so we have to be cautious. And usually the common cause of breast metastasis are from the same or contralateral primary mammary cancer, but it can be from extramammary cancer like common lymphoma, leukemia, melanoma, ovarian, renal cells, and so on. Okay. What about this lymph node? Medina.
The part of the mammogram shows multiple large, dense lymph nodes, axillary lymph nodes. By ultrasound, the lymph node is.
What else about these lymph nodes?
They are dense.
Criteria. Dense.
Dense, oval, and some are rounded.
What about the hilum and berry lesion?
The hilum is the fatty density is not shown.
Okay, losing the fatty hilum, and there is.
Yes.
What about the adjacent tissue?
It looks normal with only the lower one shows surrounding. Yes, perinodal edema.
Perinodal edema,
yes.
associated with perinodal edema. Yes. So definitely these are pathological lymph nodes and even suspicious on mammography.
Suspicious lymph nodes.
Yeah. Okay. On ultrasound, demonstrate.
The ultrasound demonstrate unequal increased cortical thickness
Diffuse.
with yes,
Diffuse cortical.
diffuse but unequal.
Lobulated.
Yes, cortical
It is
thickness.
lobulated. Yeah, it is lobulated with, but still we could appreciate part of the compressed fatty hilum is appreciated in ultrasound, which was not seen on MRI, on mammography.
By mammography. But the outlines of the capsule of the lymph nodes also shows the indistinct wall with some undulations and irregularity.
Yes, a lobulation here. It is a lobulation. Lobulations and inhomogeneity of inhomogeneous low cortex. Okay, so
yeah,
suspicion for pathology confirmations, and the patient was
because
tuberculous lymphadenopathy. See, simulating metastatic lymphadenopathy. And the other see, this is another example, but here there is no edema, just a reactive lymph node, but lacking fatty hilum and veins surrounded. Okay, but on ultrasound, still we could appreciate the cortex is
fatty hilum, which is compressed.
Yes, yeah, you see now ultrasound how it gives more characterization, more differentiation than mammography. But all in mammography giving the same, just lacking fatty hilum becoming rounded. But ultrasound give more characterizations regarding the if the hilum is completely lost or still there is some residual hilum. The cortex, if it is smooth and regular, increased thickness or just asymmetric, and even also can give and we can see the outlines of the cortex if it is there is a breakthrough in the capsules or not, and the lesion edema. And on Doppler here is not shown. Also, you can differentiate. We have seen the example of necrosis high up with reactive lymph nodes. Though the cortex was diffusely thickened, the hilum,
central only.
Yes, the Doppler demonstrates the normal distribution, even if it is increased the vascularity, but having the normal distribution through the central hilum. Okay, the hilar region. Okay.
Yes.
Compare with this metastatic lymphadenopathy. You see, from primary cancer. Here we could see the primary carcinoma more or less is similar, but look also here it is more heterogeneity, the lesion edema, and the some printing into the adjacent hilum. And if we look for the hilar vascularity here, we'll see it as cortical vascularity. So when we look for the lymph node, we have to remember that we have many benign conditions and systemic diseases can give us pathological lymph node with lymphoid hyperplasia on top of differential diagnosis, and we have to think about non-mammary malignancies giving secondary adenopathy, especially if we could not see any underlying breast lesions in the differential diagnosis. Okay? So in screening, it's common to find lymph node. And if we could see, okay, a lymphadenopathy, it's seen, they said, in 0.2% of patients with otherwise normal mammography. And we have to compare with previous. And if the patient having underlying malignancy and the lymph node enlarged by 100%, it means increasing double size, then we have to recommend biopsy. But if the patient have no malignancy and the increase in size is just a small increase in size, not much, and still preserved the benign appearance, then we have to suggest a follow-up. And most of the time, either to be stable or regressing in size, because lymphoid hyperplasia is the most common cause for this enlargement. Okay, regarding these patients. Abir.
These are MLO and CCVO of breast parenchyma ACRD, showing bilateral ACRD.
Yes, okay, but here you cannot comment on that because the breast is extremely edematous.
Yes, it's edematous.
You can go immediately for the increased breast density and edematous changes. Okay.
Showing bilateral extensive breast edema with with ligamental thickening,
trabecular thickening,
sorry,
and
with
skin
trabecular
thickening.
Yes.
Increased breast density, trabecular thickening, and skin thickening. What else?
Yes. Within the breast parenchyma, I couldn't appreciate any abnormality, but there is a left axillary lymphadenopathy.
Excellent. There is opacity in the left axilla, mostly representing. Yalla, what is next?
As I couldn't appreciate the fatty hilum within the lymph nodes.
Okay.
So
you
I
have seen
suggest
part,
ultrasound examination.
you have seen part of the lymph node. So you need to go for, okay, let me show you ultrasound. What about the ultrasound?
So the ultrasound show that there is yes, there is skin edema and trabecular thickening, and also there is well-defined
what are these? What is this? We described in the case before. Okay, this here, this
lymphatics.
Yeah, this one. Abir, the skin is thickened. Okay, and below the skin, these are
subcutaneous vessels.
Subcutaneous lymphatics.
Lymphatics, okay.
So the subcutaneous lymphatics are dilated.
Also engorged.
And below which, what are these? Can you see? Could you differentiate the breast tissue? There is lack of differentiation of the breast tissue, and there is increased echogenicity. The fat is echogenic, with lack of differentiation due to breast edema. And yeah, and there are areas. This is the edema, and there are areas of here and here and here. There are indistinct area of hypoechogenicity. Okay.
Okay.
And this is the axillary.
This is the axillary lymph node. Showed asymmetrical cortical thickening. But
so
with
you are dealing with.
hilum.
So now you are dealing with.
I'm dealing with
this
non-benign process.
Seen bilaterally. Okay, what is your differential diagnosis?
It could be fluid overload from other systemic illness.
Okay. Does
like
fluid overload
failure.
can explain this pathological lymph node?
No. Could be bilateral lymphedema.
From what lymphedema?
It's bilateral, so it could be infective causes.
Infection, okay. Differential diagnosis include infection, like, okay, mastitis.
Could be, yes.
Okay.
Could be malignant process.
Malignant process, excellent.
lymph
Like
node.
malignant process, like
I mean carcinomatosis involving the lymphatics and leading to lymphatic obstruction. So
excellent. Well done. Well done. Well done. Okay. Could this explain these hypoechoic areas in the breast? Can explain the bilateral edema due to lymphatic obstructions by metastatic axillary lymph node. Yeah. But how you can explain the breast hypoechoic, irregular hypoechoic areas? This lesion, how you can explain it?
Due to lymphatic congestion, could be.
Lymphatic congestion will give you hypoechoic, will give you edema, but
Yes.
could be give you hypoechoic lesion?
No.
No. So you have something infiltrating the breast as well.
Okay.
Seen bilaterally. Still, yeah, what is your differential diagnosis? Quickly, Abir.
Could be lymphoma.
Excellent, well done. Excellent, well done. Lymphoma. Yes, lymphoma. And it could be bilateral inflammatory carcinoma.
Yes.
Could be bilateral lobular carcinoma. Even lobular can give you just extensive edema and this diffuse process. Okay, so it can be bilateral invasive, especially lobular, bilateral inflammatory carcinoma, bilateral metastasis, or before metastasis. From the metastasis, we will put lymphoma on top of the differential diagnosis, the secondary metastatic disease. So this is the MRI for the same patient. Can you see the abnormality? Can you see any abnormality in this? Could you appreciate it? Okay.
Okay. Diffuse breast infiltration, bilateral infiltrative changes in the breast.
Yeah, bilateral infiltrative.
It's normal.
Especially this is one non-mass-like enhancement. This is corresponding segmental non-mass-like enhancement, heterogeneous, corresponding to this patchy hypoechoic lesion seen on ultrasound. Right, it's okay. And the breasts are diffusely enlarged and edematous. What else? What else? Could you see any additional abnormality?
Inside the thorax.
Excellent, well done.
There is lymphadenopathy, mediastinal lymphadenopathy.
Excellent. What else? You can see mediastinal lymph node. Yeah, in one image. This and this, you have seen these are mediastinal. And this, what about this structure? This is lower down. Usually you have seen what behind the breast?
Heart.
Heart.
The heart
is it normal heart? And surrounding the heart is?
The pericardium is thickened also.
Thickened and heterogeneously enhanced pericardium, as well as left pleura.
Yes.
You see, there is this is here mild pleura thickening on the right, while extensive on the left side. And this is the X-ray corresponding to the what you have seen, showing you what you have seen on MRI. Look for the mediastinal widening as well as lobulated pericardium with adjacent lymphatics. Look for this lymphangitis, reticulonodular opacity radiating from the hilar regions, and from the second pericardium and the thickening and the left pleural effusion demonstrate their pleural thickening and enhancement in a case of lymphoma. That was our case of lymphoma. So it is important to distinguish lymphoma and metastasis from the primary breast cancer. Why? Why it is important?
Because it will affect the management of the patient.
Excellent. Because it will affect proper treatment and prognosis is different. See, we have to differentiate primary carcinoma from other types of carcinoma. Okay. Now the floor for Hind, I think. Hindu or Suhair, I don't know. Who's the one?
I don't know. Okay, can take it.
Okay.
Bilateral CC.
No, this is different patient.
Okay.
Okay.
Okay, so the image on the right side shows the diffuse thickening of the skin, trabecular thickening. Just this no associated mass or this is just vascular calcification. And
You mean the image on the left?
The left on the, yes, this is the first image. Then in the second image also there is diffuse thickening of the skin and an increased density of the breast parenchyma just posterior to the skin. And no other associated
not trabecular thickening.
Yes, less
yeah, less more than the other one, because that one there is no parenchyma. Here there is parenchyma. If you look posteriorly, you will see some trabecular thickening. So if I will tell you these two cases, they have bilateral, same process.
So this could be associated with general causes of generalized edema, like مثلا, for example, patient with renal failure, heart failure, hyperproteinemia.
Excellent. Yeah, you think about systemic causes, but you should still remember that we can
have bilateral
malignancy as in the previous case.
Yes, and it could be bilateral.
Yes. We have to think about, we have to exclude malignancy.
Okay, so we go for ultrasound.
Okay, this one is chronic renal failure and the other one is overload due to congestive heart failure. Okay, and this one more or less the same. Okay?
Yes.
But it is inflammatory carcinoma.
Oh.
So these are mimickers.
Okay.
We have to think twice about these causes of edema. And this is an example of fluid overload. You see, the patient received or the input for her dialysis catheter in her right arm, okay, catheter shunt, and immediately she developed edema in ipsilateral breast. Here the cause is obvious. It's a fluid overload. They can remove the catheter and definitely it will resolve. So the skin edema, okay, or the dermal edema and breast edema could be either systemic or could be due to local cause, especially inflammatory carcinoma. Okay, so we have to think about this and to put it in the diagnosis. When it's unilateral, it can be due to capillary leak in case of mastitis or irritation changes, due to lymphatic or lymphatic draining like infection or malignant axillary node, or due to hydrostatic pressure like renal failure or heart failure. Okay, and other cutaneous signs other than nodules as a neurofibromatosis, and you have skin calcifications, and also there are systemic causes like renal, chronic renal failure, or even scleroderma, or syndromes like acquired hereditary syndrome and so on. And this is a 60-year-old baby with progressive vision loss. Think about it. This patient having progressive vision loss, skin and joint problems, okay? And the left MLO demonstrate dermal, vascular, and parenchymal calcifications. And physical examination, she has thickening of the axillary skin. So these combinations can give you a clue for certain diagnosis. Do you know it? If you look here, this is skin calcification, this is vascular, and here this is parenchymal calcifications. And there is thickening of that. You have a combination of dermal abnormality and the condition they call it the pseudoxanthoma elastica. Pseudoxanthoma elastica means genetic disorders. By itself, you can treat this diagnosis by combinations of factors. It involves the collagen or the elastic fibers of the skin and vessels, and choroidal of the eye. Here the clue is the loss of visions along with dermal changes. So you would think about it. It's a rare entity, but the combination of factors make you to think about it. And this is typical keloid lesions, and there is air surrounding it. However, at this point here, demonstrate skin thickening, making suspicious for or mimicker for breast cancer. Okay.
دكتور رباب معلش الصوت بعيد ومتقطع شوية. يعني سألته في الشات في كم زول قال إنه نفس المشكلة.
من وين كان واقف؟ من السودوز
يعني من قبل الكيلويد دي بشوية. أيوة قبل السلايد اللي قبل دي.
هي السودوزانسوما. اوكي. So we said
بس السن يعني فيه تقطع وبعيد يعني الصوت. بنسمع جزء من الكلام وجزء لا.
طيب we said this 60-year-old lady with progressive vision loss and skin and joint problem. Okay? Our mammogram demonstrates parenchymal. This is parenchymal. This is skin, and this is vascular calcifications.
دكتورة معلش صوتك بعيد شوية.
كده ما سامعني؟ بالعكس أنا جايبة التليفون قريب. إيه صار؟
الصوت بعيد كده. قرب المايك، أقرب السماعة دكتور رباب.
والله أقول لك حاجة، دي ما من عندي أنا، دي معناها شبكة. ألو؟
طيب بتتكلمي
أيوة.
بسماعة ولا؟
ما غيرت حاجة، بالعكس البيت التليفون كان بعيد مني، لما هسه قلت لي جبت التليفون قريب. كده سامعيني؟ ألو؟ ألو؟
أيوة لكن بس الصوت نفسه بعيد شوية. هو بعيد يعني ما متقطع لكن بعيد شوية.
طيب قلت لكم 60-year-old lady with progressive vision loss as well as skin and joint problem. Okay? Her breast, سامعني؟ ألو؟
أيوة سامعين يا بوس.
يلا her breast demonstrate parenchymal skin and vascular calcifications. So, and she has skin thickening. she has problem related to the elastic fibers of the skin as well as of the orbit. Okay? Combination. These combinations is seen with a condition called pseudoxanthoma elastica. Genetic disorders. You cannot understand, you cannot suggest it unless you have these combinations. She has choroidal layer of the eye along with skin changes and these multiple calcifications. You got it? Without this combination, it will not come to your mind to put it in the differential diagnosis. Hello?
ايوه معاكي.
يلا. The second case is keloid. And this is typical keloid and surrounded by hair. So signifies skin or dermal lesions as benign. But at this point here, demonstrate focal area of skin thickening,
which make it as a mimicker. Okay.
What about this case?
multiple skin lesion could be neurofibromas, multiple neurofibromas.
Why you said skin?
Because surrounded by air.
Excellent, Wolfman. You couldn't appreciate peripherally located lesions. There is no but are sharply demarcated lesions because partial or incomplete or complete surrounded by air giving a lucent sign. Okay, this is suggesting new multiple neurofibromas. Now here is well appreciated these signs. Okay, in a case of neurofibromatosis, not usually well appreciated as in this case. Here it is very typical. We can see the peripheral located dermal lesion and extension into the axilla. Obviously, this is not a parenchymal lesions, and here the skin lesion giving simulate another nipple or a nipple signs bilaterally. You see, this is a neurofibromatosis, and this case a circumscribed small lesions. Okay, and on ultrasound demonstrate a complex lesion with internal soft tissue nodules, and definitely is a suspicious, but biopsy revealed a benign process or benign lesions, which was schwannoma of the breast, or what is called granular cell tumors, which is a rare entity, okay, usually related to the cutaneous sensory territories. Okay, and it might be, yes, commonly or usually it is circumscribed non-calcified mass, but sometimes might appear as speculated margin even with skin changes, can simulate breast carcinoma, and already we described the neurofibromas usually seen with neurofibromatosis type 1. And there is another entity we have to think about it, and very important one, which is traumatic neuroma. This traumatic neuroma, you see, as reactive hyperplasia of peripheral nerve following injury, and usually associated with post-surgical scar, okay, and often raise the suspicious of the recurrence, especially post-wide local excisions or even post-mastectomy. So we have to think about it in the differential diagnosis of lesions in scar sites. Okay, talking about post-surgical changes, these our patients, 50-year-old, had wide local excisions and radiation therapy 3 years back for invasive ductal carcinoma, presented with a palpable mass. What do you think the cause of her palpable abnormality?
from previous mammography not available. Everything is normal except for these branching high dense opacities. So الو سامعني؟ الو
ايوه سامعين.
أيوة.
سامعين؟
ايوه.
يلا what is the cause of these densities? What are these?
Could be calcification at the site of the surgical clips.
Yes. What is the type of calcification? This is, yes, you are right. These are calcification. Is it suspicious calcification?
It is junk calcification. It's benign. It looks benign.
Yes, it is junk calcification, benign. What is the other name for this junk calcifications?
In fibroadenoma, we call it popcorn.
No, but here in this case, we call it
I couldn't remember actually.
this. Dystrophic.
Yes.
Type. Okay. The bulbable abnormality exactly for this patient is this dystrophic calcification. Type. What is the clinical significance of this? For the next follow-up, the patient now presenting with this. How could it help us if the patient developed any recurrence? Yeah, at this time she presented by bulbable abnormality, representing just these calcifications, dystrophic calcifications. So if the patient coming for the second tier surveillance or next tier surveillance, and there are suspicion for recurrence, clinical suspicious for recurrence, how we can use this type of calcification to help us, okay, in evaluation of recurrence?
The calcification marks the site of the surgery, so we will try to look in the area around this calcification for the recurrence. In addition, if there is any changes in the calcification, that
like what?
The
Disruption.
Excellent, well done. If the calcification, now the calcification are forming large single opacity, okay, or one unit. This one, we have two calcification, but each calcification more or less large homogeneous opacity. If it gets fragmented, that means there is underlying pathology make this dystrophic calcification instead of being compact to be fragmented. So it will be suspicious. What else?
Yeah.
It will be signs. It will be signs for recurrence. What else? If it displaces, that means there is a mass effect. There is something pushing this calcification from its place. Indicate there is something growing. There is something underlying growing. Okay? These are the main factors or main features that use it, okay, to help us in evaluation for recurrence using this type of calcifications. Okay.
أنا عندي بس سؤال معلش. بالنسبة للراديوثيرابي السكين سيكنينج يعني ده for 3 years بيفضل كل المدة دي؟
Yes, you don't know how it was previous. It might be much more previously and now is regressing or stable. Sometimes it might be stable for a while. Sometimes it might regress. Okay?
Okay.
Yeah. This extremely rare malignant fibrohistiocytoma. Okay? Also, it is a mimicker for breast cancer. Okay. We talk about the fibrous lesions in a stromal component, and he said a non-specific stromal lesions or stromal tissue in the breast, including fibrous, vascular, lymphatics, skins, and so on. Okay, fat, and so on. So now we talk about the vascular lesions. Regarding the vascular lesions, we have benign, like hemangioma. We have malignant, like angiosarcoma. Which one is common? What do you suspect? Which one is common? Definitely you'll think that hemangioma is more common. No. Regarding the breast, angiosarcoma is more common than hemangioma. If we have seen a lesion in the subcutaneous fat, more superficial, we think about benign lesion like hemangioma, which is rarer. If we see a lesion inside the parenchyma, we have to think about malignant vascular tumor like angiosarcoma, which is more common than an usually larger site. Hemangioma, usually small, well-defined, lobulated mass. Okay? Can present as any wide range of presentation. Usually well-defined, but can be indistinct. On ultrasound, can be hyperechoic or mixed, ill-defined. As in this case, it is mixed, and they have done biopsy, and they put the hook and make again mammography for the specimen or for the area to make sure that they biopsy the same lesion. And in this elderly lady, the pathology turned out to be just a capillary hemangioma. Regarding the angiosarcoma, okay, let us see examples. This lady, 64-year-old lady with history of left breast ductal carcinoma, who underwent lumpectomy and radiation therapy. This is very important, especially when they mention radiation therapy, okay, for a long time, usually 10 years or more, and the patient presented with breast at the site of lumpectomy or wide local excision or the mastectomy, presenting with a lump, we have to put about rare lesions like sarcomas, post-radiation sarcoma. And for post-radiation sarcoma, the commonest is angiosarcoma. Okay, and look for the clue. The patient having previous cancer, underwent lumpectomy and radiation therapy, presenting now with enlarging left breast lump, with orange, skin blistering and bleeding. See, usually associated with skin changes. And here, this is the mammographic nodular density, high density lesions. You see, at the same site of previous abnormality, or size abnormality. And on what is, who is going to describe for me the ultrasound? The floor is for me, for whom? Medina, where are you?
The ultrasound shows a heterogeneous mass with central cystic changes and
heterogeneous mass, predominantly what?
echogenic or hyperechoic.
Yes, predominantly hyperechoic, central, low
necrosis, low echogenicity.
Yes, and
and vascular.
So I will not say cystic, because I could see within the area what? Same low density area I could see.
debris or echogenicity, يعني still.
I could see vascular.
Echogenic foci.
I could see vascular echoes.
Yeah.
So
yes, yes.
Vascular echoes, I cannot say this is cystic. You see, I'll say low density or hypoechogenic lesion, and the borders is indistinct. Okay.
Yes. أيوة. Indistinct border.
Yes. So
yes.
Yeah, it is hyperechogenicity with central hypoechogenicity, indistinct margins, no posterior features, not very clear here, not shown, and moderate central vascular viscolarity within the mass. So it was poorly differentiated angiosarcoma. It was poorly differentiated angiosarcoma. The clue from the history. If you, I have one case. I was planning to present it for you in the case discussion. You see?
Inshallah.
But yeah, I have two cases. One, I don't know. The pathology is discordance with imaging. But I have one, I will search for it. I remember that I have previously one case of angiosarcoma. The interesting point here in this angiosarcoma, we said angiosarcoma usually presented inside the gland, but in case of radiation, secondary post-radiation angiosarcoma, you will see it more superficial, like hemangioma. This is one point. The other point, third of the cases can be presented with normal mammography. You might not see it on mammography at all. You will see only on ultrasound. Okay, and it has a poor prognosis. Usually the patient presented with metastatic disease. Okay, these are heterogeneous group of sarcoma. All are rare. You see, up to only 3 to 4 maximum, 3% I think maximum of malignancy in the breast representing by sarcomas. All sarcomas, all heterogeneous group of sarcomas represent about 3% of breast malignancy. So it's extremely rare. This also lesions simulating the above examples of angiosarcoma, but in this case, it is just a benign lesions. The pathology demonstrates spindle cell lymphoma, a rare variant of lymphoma. You see, same more or less, but if you look, it's sharply demarcated. It's circumscribed. It's a circumscribed. On mammography here, although the size is big, the density is relatively not very high. It's a low dense lesion. Look for the adjacent the adjacent parenchyma. The lesion is not much dense. Though they describe it as high density mass, but not very. To me, it seemed to be not much dense. Okay, and it's circumscribed even on ultrasound, though there is some heterogeneity here, but not as much as seen in the angiosarcoma. And this is the examples of high density small lesions. Okay, also can be a mimicker on ultrasound, and for a benign entity called myofibroblastoma. You see, part of the stromal component of the breast. However, the interest is common in male rather than female. Okay, it's a benign process, but also can be presented, usually can be presented as circumscribed small lesion less than 4 centimeters, but can be presented by non-circumscribed irregular lesion simulating cancer. So tumors arising from non-breast specific stromal structures, including along with the fibrous tissue, the vascular structures, lymphoid, nerve, and skin, as we have some examples of these above. So, in conclusion, mammography remains the primary imaging modality for evaluation of the breast, recognizing the potential artifacts and pitfalls, associated with mammography is necessary for appreciate and accurate interpretations of the results. Knowledge of the imaging pitfalls, their appearance, etiologies, and methods of artifact reductions is extremely helpful for accurate diagnosis and elimination of both false positive and false negative diagnosis of breast cancers. And high quality imaging, definitely including diagnostic mammography and high resolution ultrasound, as well as strict adherence to interpretive criteria for most part can distinguish between benign and malignant process, and the lesions related to duct lobular system, as we described, can mimic primary breast cancer, which may also caused by a wide spectrum of pathological disorders arising from the mesenchymal or stromal component of the breast. Because lesions should be judged by its most malignant features, and because there is sufficient overlap in the appearance of benign and malignant lesion, therefore, any new or enlarged solid mass that is not classically benign, i.e., not classically seen as hamartoma or lipoma, it might require biopsy. Recognize that many benign breast lesions can mimic at one point breast cancer and should be included in the differential diagnosis, and we should emphasize the importance of radiology and pathology correlation for these lesions to obviate unnecessarily surgical interventions. Thank you for your attention. Any questions?
Thank you, Dr. Rabab.
شكرا دكتورة رباب، ربنا يجزيك
Thank you
خير.
very much.
Okay.
Thank you so much.
You are going to overcome these difficulties and these obstacles.
إن شاء الله.
يعني البناين
نقطة
كده
دولية زي دي كده.
نعم.
نقطة دولية زي دي كده إن شاء الله.
ايوه مهمة جدا.
مهمة. شوفي الشرك ده كم شرك تحت ده.
complete false.
we have to معبرة ولا ما معبرة؟
والله
خالص والله. جميلة.
شفتوا فالقصص دي، شفتوا القصص دي فشكلها كيف اللي مرينا فيها دي؟
أيوة.
كم شارك على قولتي؟
كم شرك كتير شديد والله.
كله شارك يعني.
بإذن الله نعبر.
يعني الواحد كده من أول من بدأ في البريس كنا فاهمين إنه بس البريس ده بريس كارسينوما